Hello, everybody, and welcome back to the Health Current Summit. Today, we are wrapping up our morning session with one more discussion on the overview of new federal rules, information blocking, patient access, and Medicare conditions of participation. So, of course, I know we are before the lunch break, but at least you will be able to eat virtually whatever you'd like. So, but feel free to bear with us for the next 35, 40 minutes or so, and we are going to give, hopefully, a helpful introduction to the group on a variety of new federal rules that'll be impacting our industry. And as I say I'm joined, I should introduce myself. My name is Chase Millay, and I am in-house counsel and director of regulatory compliance here at Health Current. And I'm joined by our great outside legal counsel, Mel Solis, who is a partner with Coppersmith Brockleman and a great expert in all these various issues that we're going to be talking about today. So let's jump into a brief agenda for what we'll be discussing this morning and into the afternoon. And then I'll ask Mel to give a brief intro and get us away on our first topic. So the first item on our agenda is a new rule from the Office of the National Coordinator for Health IT. And so you may have heard a lot of buzz about the information blocking rule, or may have heard it as the prohibition against information blocking. But we're going to take the time, and Mel is going to take the time to give us a brief background on the rule, tell us how we got here, what it is. We'll talk about the various requirements that it places on providers, healthcare providers, health information exchanges, and developers of certified health information technology. So I'm going to make a brief pause. If you are one of those, a healthcare provider, a health information exchange or health information network, or a certified developer of health information technology from ONC, you may want to listen intently, because the information blocking rule likely will apply to you. Following the discussion on the information blocking rule, we're going to touch briefly on two new rules and elements requirements in terms of participating in various Medicare and Medicaid programs. We'll just collectively call them rules from the Centers for Medicare and Medicaid Services. And specifically, we'll talk about the interoperability and patient access final rules and the various requirements that it has that apply to health plans. So that's another, if you're a health plan, pay attention particularly during that time. And then finally, we'll talk about a new condition of participation that CMS released for applicable hospitals regarding ADT alert requirements. So with that overview, we're going to start with our review. Mel's going to kick us off with an overview of the information blocking final rule.
Thanks, Chase. And this is true for both the information blocking final rule and also the CMS interoperability and patient access API rules that apply to plans and healthcare providers. We are living in certainly interesting times for a variety of different reasons, but we are really seeing a fundamental sea change in how we think about sharing electronic health information. And the overarching goal behind this push from both Congress and the regulators is really to put patients in control of their health records. I think it's important to remember that the reason why we're talking about this information blocking rule in 2020 is because back in 2016, Congress passed the 21st Century Cures Act with the intent of putting patients in control of their health records. And what that means is making it easy and inexpensive for patients to get that information and to also build the structures to promote the innovation and competition to make that health information interoperable, exchangeable across multiple different systems, not just their technology platforms, but across healthcare providers and health plans, so that this can move to the appropriate folks, so that patients can get better care, and so we can reduce the costs in our healthcare system. So next slide. Now, I said this is a sea change, and I wasn't kidding. For those of you who have been working in the healthcare space for the last decade or couple of decades, we've been all living in the world of HIPAA, and we have our HIPAA brains where we think, okay, I may share health information under certain circumstances, but I don't have to unless it's an individual access request. And that's the way we've really approached whether or not we share health information. Well, now we have to say goodbye to our HIPAA brains, and we have to use our information blocking brains, because under the information blocking rule, the point at which we start at is I must share electronic health information unless there is a reason why it would be inappropriate to share the health information. And if I come to the conclusion that it would be inappropriate for me to share the health information, as we're going to talk about, I want to structure my decision to not share or to delay giving access, exchange, or use of electronic health information in a way that qualifies my decision for a safe harbor so that I will not be subject to an OIG investigation or enforcement action. So next slide. So who does the information blocking rule really apply to? Unfortunately, or maybe fortunately, it doesn't apply to everybody. It only applies to some actors in the healthcare space. And I'm talking about healthcare providers, health information exchanges, health IT developers of certified health information technology. Now, if you have questions as to whether or not you're an actor, I highly recommend going to the Office of the National Coordinators, ONC's, Final Cures Act webpage. They have fabulous fact sheets. They just released one a couple weeks ago that lays out all of the healthcare providers types that are subject to this rule, and it's a lot broader than you might think. So take a look at that fact sheet to see if you're a healthcare provider who's subject to this rule. It also applies to health information exchanges and health information networks. Obviously, Health Current is an HIE. It is your statewide HIE, but you know what? Lots of healthcare providers operate HIEs, and they might not be aware of it because they fall within the definition of the information blocking HIE. Because to be an HIE, it just means that you administer, control, or govern the electronic exchange, access, or use of electronic health information amongst two or more unaffiliated persons, and you allow for the exchange of EHI between those persons or entities for treatment, payment, and healthcare operation purposes. And in my practice, I see a lot of healthcare providers that have organized healthcare arrangements and facilitate these type of bidirectional data exchange for treatment, payment, and healthcare operation purposes. So make sure if you're a healthcare provider, you also analyze whether or not you're an HIE. And even if you're a healthcare provider, you might also be a health IT developer of CHIT and not know it. In CHIT, I mean Certified Health Information of Technology. The reason you might be a health IT developer of CHIT when you're a healthcare provider is if you're sub-licensing instances of your certified electronic medical record to unaffiliated providers. Offering certified health information technology on a commercial basis could mean that you're also a health IT developer under this new rule. Why should you care about what type of actor you are? Well, we're going to talk about that. There's different intent levels and there's different safe harbors that apply to you depending on the type of actor that you are. Importantly, when we're talking about information blocking, it's not just about the actors, it's the information we're talking about. It only applies to electronic health information. So I'm not talking about your paper records that are archived in a warehouse somewhere. I'm talking about the electronic protected health information that you're maintaining in designated record sets. Designated record sets is defined by HIPAA. I'm not talking about a legal medical record. I'm talking about a designated record set. For healthcare providers, that means your medical records, your billing records, any other systems where you house electronic health information to make decisions about individuals. That is the type of data that we're talking about that's subject to this rule. The good news for everybody, until May 2nd, 2022, the data elements that are subject to this rule is limited to those in the USCDI data elements. That's important because the USCDI data elements typically represent what you have in your electronic medical records. Good news here is it doesn't include things like cost information, which is something that you do have in your designated record sets as part of the billing records, but because it's not in the USCDI data element, you don't have to worry about compliance with respect to your cost information, at least until May 2nd of 2022. Next slide. So I've told you what information blocking rule applies to in terms of the actors and the type of data, but what exactly is information blocking? It's an incredibly broad definition. Information blocking is essentially any action or inaction that is likely to interfere with the access, exchange, or use of electronic health information if you're doing it with a requisite level of intent, unless the practice is required by law or falls into a regulatory exception. Key examples of what could implicate the information blocking rule is if you're delaying or slowing access to EHI. For example, if you have a practice of not giving patients access to their lab results until a healthcare provider reviews it, that practice will implicate the information blocking rule. Requiring that patients sign a HIPAA authorization or other consent for treatment disclosures or other disclosures that are legally permissible without having that signed consent or authorization, that is another practice that's going to implicate the information blocking rule. Charging fees, putting on onerous security requirements, like always requiring a valid Arizona driver's license to prove identity and not accepting other forms of government-issued ID, is an example of a practice that would implicate the information blocking rule. So too is refusing to send EHI to third-party applications chosen by a patient because you're concerned about the security risks, when it's really the patient's decision. All those things implicate information blocking, but the good news here is that that doesn't mean that you violated the information blocking rule. As I said, you have to have the intent and the interference. If it's required by law or falls into an exception, it won't be information blocking. So now I'm going to hand it over to Chase, and he's going to tell us a little bit about what isn't information blocking.
Great, thank you, Mel. And so let's just recap briefly this this broad new rule we're dealing with as an industry here. So Mel helped us to understand who the various actors are. So who are the various organizations who are going to need to comply with this rule? And those include healthcare providers, HIEs like us at Health Current, as well as developers of certified health information technology. We talked about what information it applies to, and we have a new definition of electronic health information, or EHI, not to be confused with PHI, but generally referring to that designated record set that we're talking about and we share among the community as a matter of course. And so now we're told that if we're one of those actors and we're talking about that information, we must share that information freely unless there is a legal something required by law is restricting us from doing so, or we have an exception that applies. So now I have the great pleasure to talk about how we can think about the various, as we see on the slide here, various intent requirements, and additionally what other exceptions are available to facilitate hospitals, other providers, developers, and HIEs to figure out how to comply and do so without completely changing their business around. So the first thing is to talk about what level of intent is required to violate the rule. And this is where we see that first bifurcation between healthcare providers and other actors. And the first thing to know is that if you are a healthcare provider, you must know that the practice is unreasonable and likely to interfere with what we talked about, Mel talked about on our previous slide, with the access, exchange, or use of EHI. That contrasts where if you're a developer or you're an HIE, you must know or you should know. So that lower bar, you should have known that you should not have been interfering with the access, exchange, or use of EHI. So the thing to note there is that ONC is recognizing providers' critical role in this, primarily providing care to individuals, and so is already setting a bifurcation to where what enforcement will look like against providers and what that bar will need to be. They need to know that they're violating the rule, versus the enforcement against other actors, developers, and HIEs, where they're either new, which is what the providers need, or they should have known. They were being reckless or some other mental intent to violate the rule. So with that in mind, let's talk first briefly about, let's just dispel a confusion. I think this is, Mel, when we're reviewing the rules and going through this often comes up as just a point of confusion in terms of what to clarify. So the first thing ONC says is, okay, you must share information unless the restriction or the interference is required by law or an exception. So let's table exceptions for a second and break down that required by law element. So required by law, as ONC states it, is something that is explicitly required by state or federal law, including tribal law. And if you look at that first bullet point, ONC does not consider laws that require patient authorization or consent, so a HIPAA authorization for disclosures outside of TPO, or a consent under 42 CFR Part 2 to disclose a person's substance use disorder treatment records. That is not required by law, primarily because there's no legal requirement to get that to go through that process. It's that it's just got procedural requirements, as we see in that second bullet points, such that the agency is engaged in a practice pursuant to a privacy law, but not required by law. So it's just something to note as we start to get more familiar with the rule, that required by law is really talking about something like a court order or some other thing that is restricting you as a matter of law to disclose that information, rather than your compliance with a consent provision, which would be compliance with the privacy exception. So let's use that as into a jumping point broadly into the exceptions, right? So we talked about to whom the rule applies, the various actors, providers, HIEs, and developers. We talked about what information, EHI, and we now know the various intent. You either need to know if you're a provider or know or should know if you're one of the other actors. And we noticed that there is a carve out for things required by law, right? Court order, those types of things. Now, this is where organizations are going to spend the time really figuring out how to adapt their processes to fit within these safe harbors that ONC has developed to allow an organization to say, I'm going to interfere with the access of exchange or use of information, but I'm going to do so within the confines of one of these exceptions. So we have actually a whole series on information blocking broadly. We're developing more materials to relay this information to the community. We could spend a very long time talking about the exceptions and sub-exceptions and all the various parts thereof. But just to note for this group that there is an exception model, there are safe harbors available, and they really do make sense. So if you think about approaching it as how should an organization reasonably share information, deferring to that must requirement information blocking, saying, okay, I need to share the information unless there is a requirement or some compelling reason not to, and diligently thinking through how to use these exceptions to develop your processes to meet the rules requirements. And we'll talk about those in just a bit. So now, with all that in mind, I'll go ahead and turn it back to Mel, who's going to talk to us about enforcement of the information blocking rule, and then importantly, how we can prepare our organizations to comply with the rule once it takes effect.
Thanks, Chase. So I think it's helpful for healthcare providers to know that this particular rule, even though it deals with electronic health information, it's not going to be enforced by the Office for Civil Rights, the OCR, which enforces compliance with HIPAA. This is something that's going to be enforced much more like the anti-kickback statute and the Stark statute. And the reason for that is the Office of the Inspector General within HHS is the entity who's responsible for investigating information blocking compliance with respect to all actor types. So if there is a complaint of information blocking lodged with the Office of the National Coordinator, the ONC, who wrote this rule, it'll get referred to the OIG. The OIG initiates an investigation. They've already said that they plan on enforcing this and investigating it just like they do with the anti-kickback statute. And what they'll do is if they find that there has been a violation of the information blocking rule and you are a health IT developer of certified health information technology, or you are an HIE, you could face up to $1 million per violation penalties for the information blocking. Now, if you're only a healthcare provider, what will happen is the OIG will refer you to the appropriate agency for disincentives. Where you get referred is going to be driven by the type of programs you participate in and the nature of the information blocking violation. So for instance, if you participate in promoting interoperability or MIPS, you're going to be referred over to those agencies and you're probably going to face clawback disincentives. If it was an individual access request, like a patient access request to information, you'll likely get referred over to the Office for Civil Rights, which enforces a HIPAA right of access. And the OCR, as you're probably well aware, is aggressively enforcing an individual's right of access. And we only anticipate the OCR getting more aggressive next year or this year as the compliance date goes into effect. Now, the compliance date is supposed to be November 2nd. However, in front of OIRA within the Office of Budget and Management, there is an interim final rule. And the title of that interim final rule references the delay due to COVID-19. So we are all waiting on pins and needles for the release of this interim final rule to see if the information blocking compliance deadline will be extended. We anticipate that it will be. We just don't know when. The hopes are that we'll have about a 3 to 6 month grace period to get ready for the start date on compliance. But hopefully we'll know more soon. I just don't know right now. Go ahead.
And Mel, just I know that's a great note, Mel, in terms of a possible extension. And Dr. Rucker alluded to that again yesterday, that even it's out of his hands and we're waiting on OMB to decide that. And I did want to just note that we did get a question from Dr. Dunnigan, and he actually asked that same question if we did have an update on any news on the potential delay. As of 5 minutes before this meeting, there was no news. It's just still sitting there on the, ready under review. And so we don't have any news up to date. I just wanted to take this time just to say also, thank you, Dr. Dunnigan, for your question. Please, others, please feel free to share any questions in the chat. And we'll work to address those throughout. So I just wanted to note that, Mel, and please feel free to, I'll advance the next slide to our next, there we go. Great.
So irrespective of when the compliance date is, move forward with getting compliant with this rule because it is a process. It is going to take you some time. In my experience, anywhere from 3 to a year to really, depending on how big your organization is, to get compliant with this rule. And here are some best practices that I've identified in making this process work as smoothly as possible. You want to start with putting together your information blocking team. You want to have an organizational leader who has the responsibility for implementing compliance at your organization. And that person either needs to be at an executive level or have the authority to report to the C-suite folks. And what your information blocking work group is going to want to do is first to get themselves educated on information blocking. What does it mean? What does compliance look like? That process in and of itself takes some time. This rule, I think the final rule preamble is something like 1,000 pages long. It takes time to educate your folks, so take the time you need to do that education. And then what you need to do is identify within your organization, where are your sources of electronic health information, and what are your practices with respect to that EHI. Once you identify what your practices are, you'll be able to identify the compliance gaps and close those gaps. What does closing those gaps look like? For most organizations, what it means is updating your policies and procedures that govern health information. That's usually your HIPAA privacy policies and procedures, your Part 2 compliance procedures, any other state law policies and procedures you have in place. You're going to want to tweak your existing policies, plus you're going to want to have an overarching no information blocking compliance policy, as well as some additional procedural documents on how you handle EHI requests as they come in so that you can take advantage of those safe harbors. As Chase mentioned, the safe harbors for information blocking compliance have lots of conditions that have to be met if you're going to qualify for them. So when you're updating your policies and procedures, you're going to want to have opened on your screen what are the conditions for the safe harbors that we want to take advantage of so that we make sure we bake those into our processes for how we handle EHI requests. Once you have your policies updated, train, implement this. You have to train your workforce members on these policies and procedures. Otherwise, you're going to disqualify yourself for some of the safe harbors. You also want to continue to monitor, investigate, and enforce compliance. November 2nd is our current compliance start date. It's not an end date, it's ongoing. This is just going to be like your HIPAA, your anti-kickback, your START compliance. You're going to do it on an ongoing basis. And depending on the type of actor that you are, in many cases, you're going to find that you need to go back and either amend existing agreements or update some of your template agreements that have to do with sharing electronic health information. So that's all the time we have today for information blocking because we want to move on to some of the other important interoperability rules that were released at the same time as information blocking.
And Mel, maybe, thanks for that. Maybe before we wrap up on info blocking, we've just got a couple questions in the chat that we can answer now while we're on the topic. And the first one is, if a provider in private practice refuses a request from another to directly integrate with an EHR, is this information blocking?
Well, it depends. We would need more facts to determine whether or not you have something that both implicates the information blocking provision and violates it. So remember, the definition of information blocking is any practice, act, or omission that is likely to interfere with the access, exchange, or use of EHI. So if you're getting a request from a third party to engage in a data sharing arrangement, whether or not that implicates the information blocking rule is going to be driven by whether or not is this request coming from somebody who's authorized to ask for the EHI? For instance, is it coming from a treating provider of patients, co-patients? Maybe you're in an organized healthcare arrangement and you're treating similar patients, and they're trying to set up a way to maybe electronically get EHI in common patients. And the ask is to share under a certain arrangement. Well, saying no or not responding could indeed implicate the information blocking provision. What you're going to need to do is look to your safe harbors and figure out how do you respond to these different types of EHI requests. And how you respond, the answer to that question is really going to depend on who is asking, why they're asking, and what their legal authority is. And how you respond in a way that doesn't implicate information blocking is going to depend on what type of safe harbors do you want to take advantage of. Is it going to be privacy, preventing harm, security, content and manner? What can you and can you not respond to? And feasibility. It's a very complicated process, but these are precisely the type of questions that you need to raise within your information blocking work groups and figure out how do we address this proactively in our policies and procedures so that we qualify for safe harbors. Chase, did you want to add to that?
Yeah, that's a great answer, Mel. I think that basically sums it up. But I would say, really, as we're at this very early stage of understanding what information blocking compliance, I would say you're hitting the nail on the head in terms of having the right people in your organization thinking about it, having a process to take in this type of request, and maybe you do wind up rejecting it, but starting to get the wheels turning about how to integrate that into a process. So that's all I wanted to add. I'm seeing more questions coming, so I just wanted to get those on as well. Mel, with regard to the definition of EHI, is EHI related to only patient information, or could it also capture other information that is not individually identifiable health information? Yeah, I think, Mel, that your audio. Okay, good. Great.
Sorry about that.
No
yeah,
problem.
I'm off mute now. Well, the answer to that question is electronic health information. The definition is that it's electronic protected health information within the designated record set. So EPHI means it has to be individually identified patient health information. So it does not extend to de-identified data. That was something that ONC was considering in the proposed rule, but they did not finalize it. And there's a related question in here about whether or not it goes to whether the information is for TPO purposes, treatment, payment, or healthcare operation purposes versus other purposes like public health or maybe law enforcement. And the answer to that question is it's not limited to EHI requests just for TPO. It could be any request for EHI, and you have to assess based off of who's requesting it and the purpose of the request, whether or not things come into play like the HIPAA privacy rule and whether or not you take advantage of the information blocking privacy safe harbor to say whether or not you could release the information under an integrated approach of those two rules.
Great. Okay, well, I think we've got time. Let's just address the last two here, Mel, in terms of the first one is where else is a designated record set concept pertinent to clinicians, developers, others? I would say that is pertinent because that, as Mel said earlier in the presentation, that comes from HIPAA. That is more than likely or not what you are sending to Health Current, for example, if you are a data supplier, and we then treat that as such as we're sharing it as well. So that's, in terms of where that applies, that is what you would share normally through a release of information or something along those lines is what I think is, not to oversimplify it, but I think is a reasonably close analogy to what a designated record set would constitute. And then finally, there's based on actor categories, are payers excluded from the information blocking rule? Payers are not in the information blocking rule explicitly. Now, as Mel mentioned, payers may also be a developer for certain purposes, or they may be a health information network for other purposes. So that's something that those organizations should consider, but payers are not explicitly an actor in the information blocking rule. And then finally, as long as a provider complies with sharing patient data, it should be fine. It does not require how the information is to be shared. So I'll step that back for a second. I know that's a statement more than a question. But I think that is on the right track to say that as long as you're sharing the data and doing so in a way that's reasonable for your organization and is reasonable, from an industry perspective, I think you're in relatively good footing. But it's important to note that you want to make sure that you are complying with all the various exceptions and that you are acting in a way that it's not just saying, well, I made an attempt to share the data and nothing more. So Mel, do you want to give any color commentary on that?
Yeah, I just want to add to the statement in the chat box about, quote, it does not require how the information to be shared. That's an end quote. Yes and no. The way the information blocking rule is set up, and I'm going to refer you to take a look at the content and manner safe harbor, is the presumption is that you're going to respond to an EHI request in the way it was requested, in the manner it was requested. So not just the content, the EHI that we're talking about, but how they want it. Do they want it through a FHIR API? Do they want a CCDA? That is how the information is to be shared. And your presumption should be, I'm going to share it in the way it was requested. And if I'm not going to, remember that could constitute an interference on how the EHI is accessed or exchanged. You're going to want to structure how you respond in an alternative manner to meet the requirements of the applicable safe harbor. In most cases, for healthcare providers, that's going to mean you're going to look at that content and manner safe harbor, and you might need to take a look at fees, licensing, infeasibility, and then also always privacy, security, and preventing harm.
Great, thanks, Mel. And that last point's a really great, I think, way to close it out. It's really important to be get familiar with all of the concepts, and then as we answer and think through all these questions, you'll really be able to apply all of those various exceptions and safe harbors and get a real understanding for how to operationalize compliance. I'll note on this topic and on others, we at Health Current are going to continue to develop materials to support you and your organization with your information blocking compliance. We're working on templates and other materials that providers and others may be able to implement. So please feel free to reach out to your Health Current account managers or others at Health Current, and we can understand the need, and we're more than happy to continue to provide education and other resources where we can. So with that note, we'll wrap up information blocking and put that headache behind us. And let's talk, Mel, first about remember we have two CMS rules we're talking about. First are the interoperability and patient access final rule, and then we'll talk about the hospital conditions of participation. So Mel, why don't you take us off on interoperability and patient access?
So if you're a health plan in the audience and you're wondering, why am I on this call if the information blocking rule doesn't directly apply to me? Well, here's why you're on this call. A number of health plans, primarily the governmental health plans, so I'm talking about Medicare Advantage plans, I'm talking about the Medicaid managed care plans, including CHIP, and then also in the Medicare Advantage, I'm including the SNP plans as well. And then also if you're a qualified health plan who's an issuer on the federally funded exchange, and Arizona uses a federally funded exchange, if you're offering plans there, you are subject to these new CMS interoperability and patient access requirements. So what are those? There's actually three: patient access API, payer-to-payer exchange, provider directory. We're only going to talk about the patient access API and the provider directory today. Payer-to-payer exchange is also a big one, but the compliance deadline isn't until January 1st of 2022, so maybe we'll do a different topic on that one next year. But to focus on patient access API, here's the requirement. The compliance deadline is January 1st, 2021, right around the corner. As far as I'm aware, there's no plans to push out this compliance deadline, so it's going to be January 1st. However, there is enforcement discretion delay until July 1st. So at least in terms of enforcement, there's a little bit of breathing room. Here's what you have to do. You have to build out a FHIR API repository, or have the ability to pull to answer a FHIR API request the following types of data: adjudicated claims data, that means your initial payment decision, even if there's an appeal pending; encounter data, these are your HIPAA standard transactions encounter data, that's what I'm talking about; clinical data as represented in the USCDI data elements. If you're a health plan, you're probably thinking, what is the USCDI data elements? Those are the data elements that represent a data policy that often reflects what you see in an EMR, like treatment plans and clinical notes. So if you have clinical data, boy, lots of health plans do, that is also subject to this patient access API requirement. And there's also a formulary and formulary utilization requirement for certain covered plans, like Medicare Advantage Part D, or if you're a Medicaid plan and you have the covered outpatient drug benefits that you manage, that's also subject to this requirement. In most cases, you have to make this data available within 1 business day, either of claims adjudication or receipt. So that's a very strict timing requirement, which also makes it different if you subcontract out these plan functions. So there's a lot to do here. If you haven't gotten started, definitely start now because it's quite a lift. The other API requirement is provider directory APIs. So this actually only applies to the Medicare Advantage and Medicaid managed care plans. If you're offering FFE plans, you're off the hook for this one. The deadline is the same as the patient access API, and the idea here is it's public facing. So not just for patients to get access to their health information, but anybody in the public who wants to get things like provider names, addresses, phone numbers, specialties. And if you're a Medicaid plan, you also have to include information like group affiliation, whether or not they're accepting new patients, and if they can accommodate disabilities. So that's the provider directory API requirement. I'm going to hand it back over to Chase, who I believe is going to talk about the COP requirements for providers.
Great, yes, and Mel, we're flying through this on our last 3 minutes here. So I do want to start by taking a bit of time to say on the new CMS COP with regard to as it applies to specific hospitals, with thanks to you, Mel, we've put together this, what I hope is a very helpful community white paper to really break down all the requirements in the COP. So that's available on our website. We have that also linked at the end of the slide. So I just want to note much more to this discussion, and that's contained within that white paper. But just as a just broadly in terms of the requirement of the new COP, basically hospitals that, including psychiatric and critical access, that have electronic medical or administrative systems, administrative systems that can support HL7 2.5.1. That's we can leave it to the tech folks to know if your system supports that, must be able, by that May 2nd, 2021 compliance deadline, to be able to send out what CMS called patient event notifications, but what we generally call ADT alerts. And so that's really what this is requiring, is that these hospitals, the hospitals that meet these requirements here, send out alerts to applicable providers as needed throughout the community. And so what do these hospitals have to demonstrate that's new? So first, they have to demonstrate that they're sending minimum patient information, including patient name, treating practitioner name, and sending institution name. And they're sending that, see, that's where we get that term patient that bullet 2, patient event notification, AKA ADT alerts, either directly or through an intermediary. That's what Health Current would like to serve as through an intermediary, and then list the various times that you need to send those. And importantly, and we'll talk about that in this next slide here, importantly, the hospital has to demonstrate, and this will be really the key here, that they have made a reasonable effort to send those alerts, those patient event notifications, ADT alerts, to all providers specified in the COP. So let's very quickly break down what those 2 requirements are. Here's our list of alert triggers and to when an event is triggered. So during ED registration, inpatient admission, discharge, all the various things we know of as ADTs. And I realize that we don't have a slide on here, but to whom does that need to go to? Who do you need to make a reasonable effort if you're a hospital to alert? You need to make a reasonable effort to alert all the patient's relevant primary care doctors or primary care practitioners and post-acute care practitioners. And so again, I know that's a really high overview of what the requirement is, but we have a white paper on that, and we're more than happy to explain that. And really, we're really happy to be able to showcase Health Current's evolution and be able to serve as an intermediary to send those ADT alerts across our diverse and growing community. As I'm realizing here, I've got the date from October 5th, and I think I'm already probably 20 or so participants at a date. So we are growing and excited to be able to share that with hospitals. So we talked about a lot today, and I know I'm rushing at the very end here, I know we're at the lunch hour. So here's some resources on information blocking in terms of where they are in the Federal Register, the code, and in various websites to help you out. As I mentioned on that last line, we've got the white paper on the CMS condition of participation for your particular review. And then finally, please feel free to reach out to either Mel or me directly. We're more than happy to provide guidance where we can, and we really enjoy kind of helping bring the community up to speed on these complicated issues. So With that, I think we'll wrap up exactly at 12:30, and I'll turn it over to Christy to send us out.